WMFD.com. It is Coffee Talk with Jay Fox on this snowy February morning in February. February twice, 3 times, 4 times a lady. And we are sponsored in part by the Cove Coffee Shop in Ontario, offering inside service, to-go service, and curbside carryout. Joining us today on the program is Brad Schwartz. He is the Pharmacy Clinical Services Manager for Avita Health System. And Brad joined about 6 years ago, and he has worked to enhance the health system's clinical guidelines and pharmacist-led services in clinics and participation in research. Additionally, he also serves as the organization's leader in the areas of antibiotic stewardship and medication safety. So, Brad, our first question for you today is, what constitutes antibiotic stewardship? That sounds like a very impressive title. So what is antibiotic stewardship?
Sure. So antibiotic stewardship is essentially the overarching goal is to make sure we're using the right antibiotics for the right types of infections, not overdoing it, not underdoing it, and just kind of making sure that we're being good stewards of treating infections, because over-treating can lead to worse infections and under-treating can obviously lead to harm to a patient or something like that. So
there have been a lot of conflicting studies that have been published over the years about antibiotics. Some saying that
Sure.
Antibiotics are good and they're here to treat and prevent. Others saying that the more antibiotics we introduce into the body, the more we compromise the immune system's normal ability, regular ability to fight off these infections. Where's the balance, Brad?
So that is kind of the balance that we have to go after, and that's we tend to lean on what we call evidence-based medicine. So we try and come up with guidelines, follow research, and follow our larger organizations. So most organizations tend to develop their own guidelines and their own consensus on, if we're going to treat pneumonia and you're in the hospital, how should we approach that? What antibiotics should we use? What's too many? What's too little? When should we use some of the quote unquote bigger guns, the more aggressive antibiotics? And that way we don't approach that state where we're potentially putting the patient at compromise of other infections or worse infections. Or if you've ever heard of C. diff, that's a big hospital-acquired infection, and overdoing it with antibiotics can put someone at risk. And so that's where stewardship comes into play, to make sure we're not overdoing it, and again, putting the patient at more harm.
And when we're talking about risks, are we talking about just liver and kidney risk, or are we talking about overall immune system risk?
Liver and kidney is one aspect, and you can have some just unique side effects depending upon the antibiotic that you may be using. But things like sometimes you hear the phrase super infection. So someone's has an opportunity for a more aggressive bug to kind of come in and kind of take over. So it kind of depends a little bit on the antibiotics themselves, but kidney issues is certainly one, liver, some bloodstream type of things, but that's kind of the gist. So yeah, good question.
Some people wonder why a specific antibiotic is prescribed for a specific condition, and how can that specific antibiotic work only in the area that it needs to work. And I'll give you an example. And this is personal. For years, I suffered from acute recurring bronchitis. And in order to prevent, and it was asthma based, in order to prevent bronchial pneumonia, they prescribed a particular antibiotic called Avalox, which was specific to the lungs and the capacity of the lungs in that regard. How do we know that when we take that pill, it's going where it's supposed to go?
So that's where all the research and effort that goes into developing those drugs before we start using them comes into play. So that way, if we know, for example, Avalox is a drug that is among a class of drugs that are just like it, called fluoroquinolones. And throughout that class of drugs, there are some that we know get a sufficient level in lung tissue, but maybe not in other areas of the body. Like, let's say if you have a urinary tract infection, it may not actually reach a concentration good enough to work in urine. Or blood, or does it cross what's called the blood-brain barrier? Can we use it for meningitis or something like that? So basically all the research that leads up to rollout of a drug as to what tissues will reach sufficient concentrations. Is it active against this type of bug or this one? Because there's a whole host of things that are gram-positive organisms and gram-negative organisms. And you hear, some of those types of terms sometimes in the media, and those different types of infections or bacteria are found in different places in your body and have different defense mechanisms themselves, or ways that an antibiotic can disrupt that bacteria.
So when dealing with COVID, obviously, COVID is a specific ailment, but COVID also comes with a whole host of other potential side ailments.
Sure.
Where is the pharmacological balance in treating COVID versus treating the actual side elements? How do you prevent the potential interaction that could be detrimental?
Sure. So that has been obviously for the last year, the challenge in kind of unraveling COVID. As it first kind of started spreading around a year ago, it was just, is it a respiratory illness? Is it something that impacts our vascular system, our heart? Some of those things, as we started to kind of experience more and more infections around the world, and people started gathering data and reporting it and things like that. Then came, here's the other things that seem to be happening, and trying to figure out what's effective in treating that, or is there anything that we can do for that, or do we currently do anything for that? So things like blood clots in the legs or the lungs, we know how to treat those. We do it every day. So some of those tools basically that we already use come into play for those patients as well. But there is definitely a balance in trying to not overreach in terms of new information coming out. So that's been the other thing that's happened quite a bit in this last year, is the rapid publication of information. And as journals or sometimes media pick up like early studies and things like that on this drug, or we're trying to repurpose this drug for something else, it sometimes gets gobbled up and starts being used too quickly before there's enough data or research or review from institutions and organizations. And so that's been also a challenge, is looking for what's that next thing that's going to help, whether it's a lung issue or a vascular related issue, or prevent heart damage or something like that. But making sure there's enough evidence to support that works, and we're not potentially just giving someone medications that aren't doing anything and maybe have a rare side effect or a common side effect that may put them at a bigger risk. And without going into too many other drug names, that's kind of been the challenge, is it's a rapid fire of information month after month after month, and trying to sort out what is appropriate therapy, and kind of again looking to those organizations that will put forth their consensus and their guidelines and their opinions on whether should we use this or should we not, or should we only go for a clinical trial if you're going to use that.
Right. So, and this is a loaded question.
Go ahead.
So in this particular scenario, are more chemicals in the body a good thing, or are less in the body?
Well, I will just give you kind of my and a good number of pharmacists' perspectives is we prefer the least number of drugs to do the job. And so when we see patients who have, for example, lists of medications they take at home that are like in the 30s to 40s, we're immediately looking for what may not be necessary here.
Right.
What things are interacting with other things that cause you to have to take something else. and finding out what can we start trimming off of this. Is this really a symptom still? Because that's where kind of a lot of, you see specialists here and, family practice here and maybe someone in Cleveland and Columbus, and you end up with this giant med list. And so quite honestly, that's what we look to do is
you mix bleach with ammonia, you have an explosion.
Correct. So we are pharmacists especially are trying to trim and use the least amount necessary.
So when we talk about the immune system and we talk about immunosupport, is there any evidence to suggest that a vitamin C, vitamin D, zinc, echinacea, elderberry, cranberry, turmeric, is there any evidence to suggest that does anything more than, put a placebo and have a nice mental feel that you're doing something, or is there a pharmacological basis to a regimen like that?
So that's been really hard to get a big consensus on in the medical community. There is some evidence here and some data over here, but then you end up with other reports that say, well, we didn't find any benefit. And so when you start piling up all of these studies, and you could have 20 and 30, and then now it's kind of weeding through all of that. And that tends to be the way that in the medical community, we try and figure out, like, should we use this, as we look for that evidence and that support. And so right now with things like vitamin D and zinc and C, there has been a sufficient amount of evidence out there that vitamin D, or people who have low levels of vitamin D, would likely benefit, or they tend to have certain types of outcomes with COVID infections. There's also the risk of herbals and vitamins and things like that, overdoing it, which doesn't get talked about a lot, but overdoing it can actually be detrimental to your body as well.
Are we going back to the same kidney and liver issue that we were talking about earlier?
It kind of depends upon what we're talking about. So, for example, too much vitamin B6 can be detrimental to your nervous system.
I see.
Too much vitamin D can be bad for your bones, actually. So it kind of depends upon what it is. And then there are some things that are just, herbal medications that don't quite have that same regulation in their manufacturing. That, are you actually getting that amount? Is there anything like extra in there that shouldn't be? As well as drug interactions. So that's, that data has been building over the decades in terms of, how do herbals interact with other medications, or how do they impact like the metabolism in your liver and things like that. But there is some data. There's some old data on vitamin C and how that may boost the immune system or interact with viruses or things like that. Same thing with zinc. So I do know a number of doctors have kind of their favorite regimen that they like to prescribe and things like that. And, we kind of go with that, so to speak. There isn't a big amount of data that says, don't you dare, do this, or don't you dare do that, in terms of certain vitamins and things like that.
What would happen if we did nothing? I'm serious.
Sure.
What would happen if we just did nothing, and whatever we eat, that's what we got? What would happen?
Sure. So we'll talk about that in terms of vitamin D. So if we were to have sufficient levels of vitamin D through diet and sunlight, that's obviously you hear a lot about. That's where we generate our vitamin D. If we had sufficient amounts of that, and we didn't have a good number of people in the public with low levels of vitamin D, I think the data behind some of those vitamin D studies would look a little different. Other vitamins that we primarily get from our diet, you probably would not see as much information, or as a bigger push for some of those things. But we do tend to lack certain vitamins and nutrients. I know, personally, I probably don't have enough vitamin D in my life during the winter months, not getting as much sunshine. And
you're not in Siesta Key right now?
Correct. No, I am in my office in Siesta Key right now.
Very good. I like the white beaches. They're lovely.
Yeah, right.
So in terms of living a healthy life and doing everything we possibly can to prevent disease, illness. What do you recommend for a healthy lifestyle in terms of a pharmacological perspective? If somebody said to you, hey, Brad, I want to be healthy and I don't want to have to rely on medications, I want to boost my immune system, what would you tell them? Because isn't that part of the stewardship?
Yes. And the really challenging part about this for most of us is it comes down to lifestyle. It's diet and exercise. It's the same stuff that, every time you go to the doctor, if you're a little overweight, they're going to talk about your weight. If you're talking about, I drink, this much soda and this is, the type of foods that I eat, and it doesn't incorporate, things like whole grains and vegetables and all that kind of stuff. That really is it. I mean, I think all of us, well, maybe not all of us, and maybe generalizing, but a good number of us, that's the struggle. Do you get a good enough diet that is balanced? What is your exercise level? Are you staying healthy that way? And that's the thing that really staves off disease and therefore medications. And
why is it that you think, and this is an opinion question, there are many people in the world who believe that, if I get sick, there's a drug for that and I'll be okay. So it doesn't matter what I do.
Sure. That is kind of the basis of some of the services that we offer, at least the pharmacist-led services at Avita, or how we try and incorporate some of our, especially our clinic pharmacists, in that, yes, you may have high cholesterol, for example, and there's a multitude of drugs that can help bring down your bad cholesterol and potentially raise your good cholesterol.
I see them in the news. Very funny that's where they are.
Yeah. But the goal is to, again, not have to rely on that drug, because whatever may be leading you to high cholesterol is not only impacting your cholesterol, right? So let's say it's your diet. You have a poor diet and therefore it's impacting your cholesterol. Well, it's also going to impact things like your overall heart health, your blood pressure, your risk of heart attack and stroke, and all of those kinds of things. So there's also certain things that just can't be reversed with medication, especially when we talk about chronic diseases. So that's where a medication with things like diet, exercise, or stopping smoking, or things like that starts to have more of a play. And you can't just solely rely on like, well, if I take this drug, I can still eat however I want because my cholesterol will be low. Well, you're still kind of at risk of other things too, diabetes, and again, heart disease and things like that. So that's why we try and also emphasize through education, basically. So not just talking about like that drug, but talking about the implications for the rest of your body and kind of coupling that with things you can do.
But it's not a one size fits all. It's highly individualized because, I mean, you could look at somebody like George Burns, the comedian who lived to be over 100 years old.
Sure.
And he had a cigar and a glass of scotch every single day. Sure. And he ate red meat and,
sure.
Right. And he lived to be over 100. And then you look at somebody who, may have been more athletically inclined, mm-hmm. and for one reason or another didn't make it out of their 40s.
Yeah. Yeah. And that's where your genes basically come into play. A lot of medication is intended to be does this dose work for the most people? Mm-hmm. Does this dose or this drug work for the most people? And then there are people who it doesn't work for. And that's kind of where the emerging, I guess, field of precision medicine comes in. So if we can really start to individualize those things and actually take a look at like your genes. For example, we do that with heart attack patients at Avita, where we can take a look at a specific gene and how they particularly may metabolize a particular drug and see if they're a good candidate to take it or not, versus kind of the one size fits all approach where it's like, this is the drug we give everyone after a heart attack. but certainly it's your genetic makeup, and it's a lot of that nature versus nurture kind of stuff. So, what did you start with genetically, and
Right.
are you predisposed to things like cancer or other or chronic diseases or things like that?
So COVID has added quite a few wrinkles
Sure.
into the world of taking care of individuals.
Yeah.
And let's talk a little bit about how social distancing, um, fear has led to staying home for some people. They don't, they're not going to take a chance. Doesn't matter if they wear 13 masks, they're not going out,
Sure.
but they're staying home. They're feeling isolated. That isolation leads to loneliness, which could exacerbate depression and anxiety. And of course, we're in the core months for seasonal depression here in
Sure.
North Central Ohio. So, how does the treatment of the after effects, if you will, or the side effects of a pandemic affect the medication regimen?
Um, I think to kind of go on to the topic that you were talking about there with the untoward effects of things like quarantines and lockdowns and closing this and closing that, has been a concern of the mental health community,
Mhm.
the substance abuse and addictionologists and things like that. And that's where those types of organizations have really tried to do more and start calling more attention to their fields. I part of an organization that I sit on is the Crawford County Prevention Coalition, and we're still working through that. All of my time isn't dedicated to COVID. It's, there are some tasks and things. It's been challenging to keep up with certain aspects of that, but we're still doing things like drug disposal things, and the group is still doing outreach and things like that, because that is still a part of what's going on and has actually been exacerbated by that. Mental health professionals have jumped on the telehealth option right away to try and reach more people, because if people aren't coming out to go visit mental health professionals, then that obviously exacerbates that problem. But
Sure.
things like telehealth have been a huge tool to help facilitate that kind of stuff.
Well, I sit on the board of the Know It Before You Need It campaign in Richland County, and our warm line has been right
Yeah,
off the hook.
sure,
Yeah,
sure.
because people need someone to talk to.
Yeah, and that's, I think, been an additional challenge, but also good to see that people are calling attention to that need, and we're not just kind of ignoring it because COVID's over here, right? There are still people who are focusing on it, putting more effort into it, and realizing that there has been a bigger need for that. So that's, in my opinion, been great to see, because it hasn't just been kind of ignored.
But we don't want to dive into Aldous Huxley's Brave New World and give
Right.
everyone soma so that they feel good.
Correct.
Not
Correct. Correct. So, in terms of what that does for medication therapy, it presents a challenge, because if someone is trying to interact through telehealth, or maybe just avoiding healthcare altogether because they don't want to, say, go into a clinic or a hospital, it creates that challenge of, are we getting someone the right, maybe cognitive therapy, as well as maybe potential medication or changes in therapy, and kind of doing that follow-up that certain types of medications may need. It certainly has created that challenge.
now you have a unique background. How does one get from massotherapy to pharmacy?
Sure. So,
And
I,
what are you doing after the call?
sure, sure. So, that was something I did. I did that while I was in pharmacy school. I kind of
Okay.
doubled up on degrees. I have a, at the time, it was all because of a girl, to be quite honest. So
Always about a girl, isn't it?
sure. So I had an initial interest in complementary and alternative medicine, even while I was beginning pharmacy school. Um, Julie, my wife, we met in college, and she has fibromyalgia. And
Hmm.
I reached a point where I felt like I wanted to learn a little bit more, and about how to help her, basically. And so masotherapy was one of those. And what it went from an idea is like, maybe I could take a, a certificate course or something, just turned into a degree program.
So from a physiological standpoint, the power of touch is undeniable. And when the human body is manipulated or touched in a certain way, it produces endorphins and other hormones that allow the body to feel good and enhance the overall healing process. To what degree does that level of therapy and maybe homeopathy assist in the pharmacological process?
Quite honestly, that's why it's called complementary. There are certain things, whether it's acupuncture or massage therapy, and at times chiropractic, that need to complement medications. Medications aren't always the sole answer for a problem. Sometimes there are just physical aspects of disease, injury, and things like that, ranging everything from surgery to physically correct something all the way down to, adjustments and tweaks to the body, because there are certain medications that they don't actually fix the problem. They may help with symptoms while your body works on fixing the problem. And if your body's not able to fix it, that's where certain things, again, everything ranging from surgery to minor tweaks and just kind of allowing your body to work through that healing process, come into play.
Okay. What is the Pharmacist Rehabilitation Organization? Is that for bad pharmacists who need to get better, or what's that about?
That is an organization that is pretty near and dear to my heart. I've been a part of it for about 15 years, and that it works to allow pharmacists to re-enter the profession if they've been out of it, usually for chemical dependency type of reasons. So usually those pharmacists will spend a number of years out of their profession and have milestones and goals and things in terms of therapy and working with the board of pharmacy and kind of working to get them to a safe point where they can re-enter the profession.
Is that a risk to be? Is that kind of like being an alcoholic who's a bartender? Is it a risk?
It is chemical dependency is a high risk just in healthcare across the board, from things from stress and access and things like that. It has a higher incidence than the general public.
I see. Well, what is? Yeah, I don't want to end on a low note. So
Sure.
Let's circle back to best practices. What is your advice for the individual who may be watching this, who is reliant on their physician for information, is prescribed medications? To what degree do we get the pharmacist involved in the consultative process so that we as consumers can better understand what our medicine does, when to take it, how to take it, et cetera?
I'm a big proponent of taking the time to talk to patients when they first start on a medication, especially if it's going to be something that is chronic. And that's how we have our outpatient pharmacy in Ontario. And that is a big cornerstone of how they function. And not just that first time that you were there to pick it up. They do follow-up calls to double check and see how things are going. And that is a little bit lost at times when you're kind of hitting the drive-through at, one of the chain type of stores. But to me, that is the really important part that a pharmacist plays in medication therapy, is that opportunity to stop, educate, because it's not just about that drug. We can also talk about, maybe a disease, a condition, or something acute that's happening. We again have clinics at Avita that are just led by pharmacists, and a good portion of that is education from not just the drug side, but also learning about your disease or your condition, whether it's atrial fibrillation or high cholesterol, or even learning about diabetes, and kind of really wrapping in a level of understanding that is easy for the patient to understand what's going on in their body and what the medication is going to do,
Right.
and kind of the goals of those therapy, because that's also the really big important point that a pharmacist can help emphasize is what's the goal of taking this.
Were you surprised that people were, and not a lot of people, but some people were reticent to accept and receive the COVID vaccine? Were you surprised by that?
No, quite honestly not. I wasn't all too sure how it was going to go response wise, to be quite honest, because there were a lot of unknowns leading into it. People had a lot of questions, and quite honestly, between myself and my director at Avita, we've spent a lot of time just talking about vaccines. Whether it's just the general concept of vaccines or the COVID vaccines themselves, a lot of education and talking. And quite honestly, for us, it's also reading up, because as they come out and put out new information and trying to keep up to speed and answer questions or unique situations, because that's the other thing is, people have a lot of their own unique situations that sometimes are a cause for a pause and a question. And maybe that's what's holding them back from going and getting a vaccine.
So when we read that the second dose of the vaccine, quote unquote, wakes up the immune system, it's a
Sure.
rude awakening. What does that mean? What's going to happen?
Sure. So, as you know, both the current vaccines in use in the U.S. are 2 doses. The first one, essentially, you see the word primes. It kind of primes the immune system and gets it ready to start making some of the antibodies or other cells that it needs to kind of counteract the virus. And then so as it has done that, those things start kind of hanging out in your body because your body's not sure, like, are we about to see this again? Are we going to have a bigger infection? Something like that. But really what we've done is we've just essentially trained the body to just recognize this tiny little piece of the virus. So it doesn't know that there really isn't an infection happening. It's just kind of hanging out. And then when that second dose comes around, it sees it again, those little spikes from the virus, and it's already primed, ready to go. So it kind of goes into effect a little bit more aggressively or a little more diligently, so to speak. So it's already kind of made some of the things that it needs to make to kind of counteract those that presentation of those little spikes. And so therefore, when you feel ill, like when you don't feel well when you're sick, that's really your immune system doing its job to try and eliminate something. So that's where those untoward effects kind of come in.
So we have Pfizer and Moderna. Those are the ones that are on the market right now.
Right.
Johnson & Johnson is coming behind, and also AstraZeneca. What is the difference? I heard Dr. Fauci say it doesn't matter what vaccine you use, just get vaccinated. But then I've heard, well, maybe we should
sure.
Right. What's the difference?
So that the general goal, and Fauci, is quite honestly right. It's about getting vaccinated and getting that ball rolling. The vaccines that have come out are beyond expectations in terms of efficacy. So we were quite honestly pretty impressed and astounded at the level of efficacy, because not all vaccines achieve that really high level. But that's also in a sense where, the Pfizer and Moderna vaccines, that's kind of where that second dose comes in, because obviously with the single dose, you start to get some level of immunity, but to really get it to that top tier, that 90 to 100%, threshold, that's where that second dose comes in. The difference between them is not too much between Moderna and Pfizer, excuse me. The differences are kind of not much, other than how are they delivering it, what other things are in that vial in terms of salt or sugar, to kind of make sure it's kind of stable in its vial until it gets delivered as a shot. Johnson & Johnson being a single dose, it is a little bit different in how it actually delivers the recipe or the training instructions, so to speak, for your immune system.
Well, we will see how that all plays out.
Sure.
Because we have different strains of the virus now, different mutations. And with any pandemic, as we go back in history, we know that, one level of treatment may work for one thing and it may not work for others, but we can remain hopeful. And I guess what you said was the research and the study will continue and persist because, basically, we're fighting off insect infestations that keep mutating.
Yeah, and that's the good news is just because we have a couple of vaccines out doesn't mean the researchers went back to the other stuff that they were working on, right?
So this isn't going away anytime soon.
Correct. There's still a lot of people working on it. And so as some of you hear some of those, the variants and things, they continue to start looking at new variants. Does this vaccine seem to work? Do we need to do a booster shot maybe? Or if you got this, can you get this as a second dose? So there's lots of things starting to be even studied further, even with the vaccines that are out.
Yeah, I still have a giant scar on my arm from when I was a little kid from that gigantic booster shot, which prevented me from getting everything.
Right.
Right.
Right. Right.
Brad Schwartz is the Pharmacy Clinical Services Manager for Avita Health System. We thank you for your time today. You have been watching Coffee Talk, a service of WMFD TV News, brought to you in part by the Cove Coffee Shop in Ontario, Ohio, and available 24/7 at WMFD.com. And we thank you so much for watching.